Bom, boa noite a todos. A gente queria agradecer a todos que têm participado das nossas reuniões, esses webinars que a gente tem feito. Nós conseguimos essa semana, com a presença de todos vocês, atingir a marca de 500 mil de visualizações. Isso é uma coisa que deixa a gente extremamente feliz. E a gente sabe que grande parte dessas visualizações deve-se à qualidade das pessoas que a gente tem convidado, que nós temos trazido para participar conosco. Então, eu gostaria de agradecer especialmente a doutora Emily Conant, e mais especialmente ainda a Fabiola Kestelman, que nos ajudou, que convidou a Emily para que a gente tivesse o prazer e a honra de ter a doutora Emily Conant conosco essa noite. A Fabiola é médica radiologista, especializada em mama, da Clínica São Vicente da Gávea e da Clínica Cavallieri. E a doutora Emily Conant é uma das principais pesquisadoras sobre novas tecnologias em diagnóstico de mama, incluindo tomossíntese. Ela tem mais de 180 artigos publicados em revistas com peer review. Ela é chefe do serviço de radiologia de mama da Universidade da Pensilvânia e vice-diretora também desse departamento. Eu vou convidar o nosso colega João Henrique para que o João possa fazer as apresentações em inglês e a gente dá continuidade à nossa live. Espero que todos curtam. O nosso chat está aberto, as perguntas, no final a gente quer responder, e quem puder curtir e compartilhar com a gente agradece. Uma boa noite a todos vocês.
Obrigado, Eduardo. Welcome, everyone. It's a great pleasure to have you all with us today in another live of Câncer de Mama Brasil. And in this task that we have to bring updated information from world-class speakers who are on the top of the game on their research in breast cancer diagnosis and treatment. And we hold with great anticipation the conversation we're going to get today, because we're going to be discussing high-end breast cancer imaging. And we are very fortunate to have Dr. Conant from Philadelphia and Dr. Fabiola Kestelman from Rio. And I will hand over to Dr. Fabiola to introduce our distinguished guest tonight. Please, Fabiola.
Thank you, João. It's a distinguished guest. It's indeed. It's an honor. It's a privilege to introduce Emily Conant. She's more than the most knowledgeable researcher in imaging of breast, but she's a friend also. and she's very nice, and this is the best part. So, Emily, do you want to begin?
Yes, obrigada. Thank you. It's very nice to be here, and certainly I hope you all are well, and I look forward to questions at the end. I'm going to be speaking about tomosynthesis, and I have a couple disclosures, some grants. I do have a grant with Hologic, which is the industry that we use at my hospital for tomosynthesis. Also with iCAD, which is a AI-driven CAD program. Had a couple grants, and then most importantly, we were able to do something very unusual at our hospital. Back in September 2011, because we were opening up a new site, we were able to start with tomosynthesis for all of our patients for screening. So one day we basically flipped the switch and began offering everyone tomosynthesis for screening, and then we began offering it later for diagnostic patients, and then we actually implemented synthetic imaging with tomosynthesis and switched totally to just synthetic with tomo in 2015. So tonight I'm going to talk about some screening outcomes, diagnostic outcomes, a little bit about synthetic imaging, and then really just tricks of how to find lesions and how to interpret tomosynthesis, because it's not always as easy as it seems. So the deal about tomosynthesis is that it builds on a digital platform. We could never do this on the old film screen platform. We need the pixel data so that we can recreate a quasi 3D-like image for presentation. And because we have this quasi 3D image set, we can decrease the effect of superimposition and peel through the multiple layers of the breast tissue to improve lesion conspicuity. And by seeing the lesions better, we can both improve detection, so finding more things, but we're able to characterize them better as benign or malignant. So that's a combination of improved sensitivity and specificity. So the first big thing, at least, in the United States, we have a very high recall rate compared to Europe, and I think compared to Brazil. On average, it's often 10%, which is really quite high. That may be because of our legal environment and the fear of ending up in a courtroom after missing a cancer. But tomosynthesis has brought down that high recall rate significantly. Here's an example of such a breast. Now, you might look and say, what is that area? It's the densest area that catches your eye. It also has a sharp back line. And on this cropped view, perhaps you might think there is some speculation or distortion. And that's the kind of site that one might call back as a focal asymmetry to do additional imaging from screening. So is recall necessary? So this is an example of the tomosynthesis multiple slices, 1 millimeter reconstruction that you can see going through the breast tissue. And basically you can see that this entire area of asymmetry is just superimposed tissue and ligaments that give you that appearance on 2D of being perhaps a spiculated mass or at least an asymmetry. And I compare this to pickup sticks, which you probably played when you were a kid. And the idea was the sticks fall and you are to peel them off one by one without disturbing anything underneath. So layer by layer, removing these sticks. And to me, that kind of looks like a spiculated mass there, that pile of pickup sticks. So no recall is needed because you're able to work through this on the tomosynthesis slices. Here's another example. This is actually a synthetic image, but I've circled an area, and here's a cropped mag that looks like a small spiculated mass at the margin of the tissue on this MLO view. Now, this one is very interesting. Remember that most of the tissue is in the upper outer quadrant in most women, and because of a 45-degree angle, you frequently get superimposed coming and going ligaments that can appear to be spiculation when they're superimposed. So let's look here very carefully. And this one you have to follow me a little bit. But what I want you to pay attention to is what I call the localizer stick or the yardstick. These are multiple images in the right MLO, the slices of reconstructed tomosynthesis. And I've put in orange here the position of each of these slices as we go from medial, or actually lateral to medial in the breast. And now I've magnified, showing you that each of these slices represents a different component of what was superimposed to give you the appearance of a spiculated mass. But what spiculated mass that small would extend from the lateral breast all the way over to the medial breast? That just doesn't happen. So by peeling through the 1 millimeter slices, you know that no recall is needed here. While on 2D, it looked quite concerning, but no recall is necessary. So the recall reduction here, the combination of the European studies on the top and the non-European, mostly American studies on the bottom, you can see that most of the relative risk of recall has been decreased. Now, there are a couple European studies up here where the recall rate was already around 4% that did not show a decrease, actually showed an increase, possibly reflecting the improvement in cancer detection. But in general, the recall rate in most European and then the American studies have ranged from 15 to 37% improvement in recall. So let's look at cancer detection now. This is the big one, I think. Now here's a woman with very complex breasts. The first thing you might see is this area here, which we were concerned about. However, on the 2D imaging and the tomosynthesis slices and a targeted ultrasound, nothing was seen in the left breast in that area. However, when we looked at the tomosynthesis slices of the right breast, here, you'll see a subtle distortion or spiculated mass there. And on the MLO view, sort of a tangle up there and subtle distortion. Let's see if I can get that back here. I think I have it mag too. There you go, magnification views. A little more evident in the cranial caudad view than the MLO view, but again, triangulating, this is the same lesion. We used to spot compress these and it disappeared. But now we've learned that with tomosynthesis, you can actually spot things away. So if your pretest probability of an area of distortion is seen on the tomosynthesis, this woman deserves a targeted ultrasound. And indeed, there's a small, irregular hypoechoic, taller than wide, small cancer corresponding to that area of distortion. That was an invasive ductal carcinoma with some DCIS. But that spot compression totally effaced it. So you must rely on the tomosynthesis images and really have no hesitation to take a woman to ultrasound and target. Here's another case, and this one's quite remarkable. What if I tell you that this woman has a 6 centimeter cancer? Pretty impressive, right? She's not all that dense. Well, where is that? Well, immediately, you know, what 6 centimeter cancer can I see well? Well, an invasive lobular, right? So here, let's look here. And in the lateral right breast, out in the lateral tissue, whoops, where is it? Right in there, I hope you can see that, is an area that has subtle distortion. Now, if we look at that localizer, it appears to be sort of halfway between the foot and the head in the reconstructed stack. And so we look on the MLO view and it's very hard to see. As a matter of fact, there's a wrinkle in her skin and a wrinkle here sort of confounding things. But when we play the video, you can see subtle distortion out in this area of the breast. I'll show you cropped views. There's her 2D MLO. Here's her tomosynthesis image. Distortion there. Targeted ultrasound was performed. Multiple areas of hypoechoic irregular shadowing. She actually went on to have an MRI. And I'm embarrassed, there's a little bit of motion artifact here, but corresponding to the area seen on the MLO view is an area of irregular enhancement. Indeed, this was a 6 centimeter invasive lobular carcinoma, which makes sense. But again, you know, hard to diagnose. She's not very dense, so it's not all about density. It's really about being able to go scroll through the layers of superimposed tissue to see with more conspicuity areas of abnormality. And so it's not all about density. It's about the complexity and the layers of the breast that we want to better see. So increasing the conspicuity of lesions. Here's something that we've learned over the years, which I find very, very interesting, that more often, like on that last case and the case before, things are a little more conspicuous or seen only on the CC view. So here's the tomosynthesis slice. I'm not sure whether I would call the distortion here, but clearly on the tomosynthesis slice, 2 spiculated masses with bridging ligaments. On ultrasound, 2 separate irregular masses. And this is only seen on the CC view, not on the MLO view. And when we thought about this, we realized that the CC view, if the area is within the compression and the field of visualization of the breast tissue, there's actually more force applied directly on the tissue in the CC view, spreading tissue better and making lesions more conspicuous than on an MLO view. The MLO view is fighting often with the thickness of the pectoralis muscle, the axillary tail, and sometimes the belly is in there. So the force is not compressing directly on the breast tissue. So we looked at this a little bit more, and we've done a couple papers on this. One was included just in the radiographics, and then another one in a reader study where we looked at 197 consecutive cancers detected by tomo. And we had 3 readers look at them and grade them by modality and by view. And in effect, this is what we saw. Frequently, cancers are more conspicuous or only seen on tomosynthesis, about 30%, as you can imagine. But look at this, 29% were better seen on the CC than the MLO if they were included in the field of view. These were invasive cancers. And again, more conspicuous. I'm sorry, these were all cancers, but more conspicuous on the tomo than the 2D, which makes sense. So the takeaway message from this is that if you see something on one view, particularly the CC view, pay attention to it, and really the woman deserves a targeted ultrasound. 5% were seen only on the CC view. So our industry, I told you we use Hologic. I think it's very good to have 2 views obtained with tomosynthesis rather than maybe only an MLO and just do the CC and 2D. I really believe in doing both views projections in tomosynthesis. So again, this is the big sort of meta-analysis of invasive cancer detection. Again, the European studies up there and the US studies down below, most of them showing a trend towards increasing cancer detection, again, invasive cancer detection with tomo compared to 2D, about 15 to 30%. When we break it down and look at age and density, of course, important things. There's always a big controversy in the United States about who to screen, when to start, whether we should be screening average risk women between 40 and 50. And certainly, what about breast density? Big discussion in the United States about supplemental screening for increased breast density. But what we found, and this was our JAMA article from a multi-center trial looking at almost 100,000 women with multiple screens. Most of them had 2 screens. And we looked at the outcomes at the patient level by age, density, and whether it's their first or subsequent screen. And then we looked at the invasive cancers. I'm not sure if you've heard of the TMIST trial. It's the big prospective Akron tomosynthesis versus tomosynthesis versus 2D trial going on in the United States. They have a criteria of advanced or poor prognosis cancers. So really beginning to combine the biology and subtypes of cancers in our outcomes. And this criteria of advanced or poor prognosis cancers includes any cancer that has metastasized beyond the breast or involving axillary or other lymph nodes, an invasive cancer greater than or equal to 2 centimeters, or the biologically bad or worse acting cancers, ER, PR negative, or HER2 enriched with a size limit of greater than 1. So those are generally worse prognosis cancers. So the size considered to be an advanced cancer of those worse prognosis subtypes is at 1 centimeter. And so when we looked at our outcomes from this multi-center trial, what we found was a lower recall rate, even when adjusted for age, density, the different sites. They were a combination of academic sites as well as community sites, as well as the first screen or subsequent screen. And this was true across all ages and densities, statistically significantly lower recall rate and a higher cancer detection rate statistically significantly, and particularly in women 40 to 49. And I'm a big advocate of screening women 40 to 49, so I was very happy with that result. And interestingly, we found that there was a higher proportion of smaller cancers, node negative, in that younger group. Now, we know that cancers are frequently faster growing in premenopausal women. So finding small cancers in these women, I think, is very important. So this was good data at the patient level. Let's look at this woman. She's crazy dense and she has no calcifications for her cancer, but she's got subtle distortion. So we're going to see that even with a really dense breast. And we can see it triangulates again to the lateral breast on this localizer or yardstick. And then over here, again, on her cranial caudad view. And here's her MR. Now, her extent of disease on MR is longer. She had this area, which was the invasive ductal carcinoma, a high grade. And then she also had high grade DCIS extending for farther along that we did not detect mammographically, but we did see the index lesion. So what about the actual cancers? We've talked a little bit about subtypes of cancers, but how do they differ from the tomo detected cancers from the 2D cancers? Many people have suggested that we're just finding ER/PR positive, slow growing, distorting cancers with a little bit of calcium a year or two earlier, and it's really not changing the long-term outcome of the patient. Maybe her lumpectomy and breast conservation surgery is a little bit smaller, but in the long run, we're just finding cancers a little bit earlier without really impacting long-term survival. We don't have mortality data. So let's look at this data. So what about tomo-only detected cancer? Well, here's one. Again, I'm going to magnify it. Hard to see on the 2D mammogram here on the left, a little bit easier on the tomosynthesis slice. And again, this is a distorting spiculated cancer. It's an ER/PR positive cancer. Again, that's the majority of cancers. So yeah, we're going to find more of those with tomo. There have been a couple papers looking at this one. This is in 2017. Again, looking at both screening and diagnostic cancers seen on tomo only. About 9% were tomo only. And they were seen to be smaller cancers, more often in dense breasts when seen only on tomo, but luminal A, which are the more common ER/PR cancers with a low Ki-67 or low proliferative index. This is a study from Mass General, 2018. They actually saw no difference in size, grade, or nodal status, and no difference in cancer detection, interesting, comparing 2D to tomo. And this is a paper that we published last year, again, that I showed you, that we actually found more often less advanced cancers in these younger women, small node negative, which we thought was a good thing. But now I want to show you a brand new paper that we just published this year, which I think is really interesting. Again, this JAMA oncology paper was neat because it was a lot of patients from multiple sites in the country, big numbers at the patient level, but it was actually not a very diverse population. The only diversity was from University of Pennsylvania, where we have 50% of our women are Black or African American. So I want to show you now our data that we just published from 5 years of screening with cancer registry follow-up on our population, because our population is different. And this was diluted by the larger number of cases in our JAMA paper. Again, we showed an increased cancer detection rate, a decreased recall, and a decrease in false negatives. But we found more advanced cancers in our tomo than in our DM. And this was because I believe we've had a very high proportion, 50% African American or Black women. And again, they frequently have more aggressive cancers at a younger age. So what this really means is that we need more data. We need more data from diverse populations. And of course, the real gold standard is mortality outcomes, which we will not have for many years. But interesting. Okay, what about false negatives? Well, there are always false negatives, unfortunately. Here's an example of a woman who is incredibly, I don't think I've seen a woman denser than this. And she had a negative tomo and 2D mammogram and then presented 3 months later with a lump in this breast. Targeted ultrasound showed this, very hypoechoic, irregular mass, no calcifications. This is a classic appearance of a triple negative. And indeed, here it is, a round enhancing mass on her MR that we had for staging after we biopsied. And this is a triple negative cancer in a young woman and a Black woman. Here's a chart of false negatives of some of the larger trials. Again, some of them are retrospective and some of them are prospective. But what you'll see is there's a general trend of decreasing false negatives in most of these. This next one, it's the same. That's the one from MGH. Skane from Norway actually has similar, maybe slightly higher false negatives, but their false negative rate is higher than ours in the United States because remember, they don't screen as often. They screen at either 18 months or 2 years. And then again, decreasing, and here's ours decreasing. None of these are statistically significant. Whoops, sorry about that. None of these are statistically significant. And when one models what number of cases you would have to accrue of screens, it's up in the hundreds of thousands to show a statistical significance in these types of numbers of false negatives between 2D and 3D. So most show a trend of decreasing false negatives. So what about synthetic imaging? Let's talk about that a little bit. the reason that we do this is really because of the dose. A combination, 2D digital mammogram and a tomosynthesis is a lot of dose to a woman if she's going through routine screening every year or every 18 months. Here's an average dose per view for a digital mammogram, about 1.2 milligrays. A tomosynthesis acquisition, remember, it's more than just a 2D mammogram. Even though there are multiple low-dose images added together, it's about 1.45 or 1.5. If you add that together in a combination, it's about 2.65 milligrays. If you can take away the 2D component of that dose, it will go back down to 1.5, still more than a 2D digital mammogram, but what you get is that 3D reconstruction of the tomo. So there you go, about a 45% reduction in dose if you can provide synthetic for your 2D version in the combo tomo. So how do they do this? Again, this is the industry that we use. There's a stack of tomo slices here. And then the industry takes a full slab thickness of all the 1 millimeter slices. Here you can see this slabbed, stretching from one end to the other of the reconstructed slices. And then they use a secret formula or a secret recipe that actually enhances different areas so that you can see the spicules a little bit better. It averages out some of the fat and some of the glandular densities, but enhances areas to make it more 2D-like. And that's driven by a MIP to create this 2D-like image. And I just want to show you this woman's cancer. And you can see how in the slab, it's a little bit hazy, but in the reconstructed, which is again driven by a secret recipe or really artificial intelligent machine learning type reconstruction, the ligaments are enhanced, the calcium's a little bit enhanced, and it's much easier and more conspicuous so that we can therefore diagnose this invasive ductal carcinoma at that margin of her dense glandular tissue. So it's really also more about dose. We need a 2D image. We can't just look at the tomo slices. We need the 2D image for interpretive tasks, such as a density assessment. To compare to prior studies, it's the fastest way to look for asymmetries without having to go through every slice of every year. And it's especially good for calcium and, as I said, asymmetries. And it's really necessary for high volume screening. So we need that 2D image, but we just don't want the dose associated if we can get away with a synthetic. And so here's some examples of synthetic reconstruction. Now, I have to say that the reconstruction algorithm has definitely gotten better over the years since we began in 2011. But it is very interesting to see how some lesions are more conspicuous. So on the left here, you can see her 2D image. And I'll tell you, there's a little invasive ductal carcinoma hiding in there. You can't for the life of you see it on the 2D. But now on the tomo slice, I think you can begin to see this subtle distortion. Looks kind of like a little tubular carcinoma, perhaps. And look at the tomosynthesis now, the synthetic reconstruction version from the tomo slab. And you can see it's slightly enhanced. It's a little bit more conspicuous. There's a little more contrasty image with the spicules showing up a little bit more. Here's another example. Here's some very subtle amorphous calcifications in this area, sort of low density for calcifications. And here they are now reconstructed and enhanced on the synthetic imaging. And again, this was DCIS. So actually, in this case, they're more conspicuous on the synthetic imaging, as you can see. Oh yeah, that's called synthetic pop. I hope you heard that sound effect. That's supposed to keep you awake also. Anyway, and here's an example of false positive reconstruction. Here's the synthetic images, and here's my electronic mag, but you almost think that there's calcification, very subtle in that area. And you wonder, is that real? Is that pseudo calcifications? And we actually brought her back because we thought those were indeed real calcifications. And we did a magnification view with 2D mammography, real, digital mammography, and there are no calcifications there. So this is actually sort of a pseudo calcification on reconstruction by that enhancement algorithm of the synthetic image. So important to note that this can happen. You look at the source slices of the tomosynthesis, see that you can see calcifications on each slice, and if you need to, you recall her. Now, we thought we were going to be increasing our recall when we started with synthetic because we thought we saw a lot of examples of pseudo-calc on synthetic imaging. And so I will show you our outcomes from our analysis of that. Here's another really important lesson. Here's some very subtle calcs. I magnified it here on the CC. I'm not sure you can see those very well, but it's a focal cluster that you all would be all over and saying that's early, that's probably DCIS, but there was nothing on the MLO view at all. Those are real and worrisome calcifications on the CC, but on the synthetic, you see nothing. So what do? You go to the tomosynthesis, you still don't see anything on the slices. So go to the projection images. Do you have those on yours? And what you can see is, number one, the reconstruction of this coarse calcification by her nipple on the CC is in a straight line showing that she did not move. But now, on her MLO, do you see how that reconstruction, there's a little bit of a wiggle? It looks kind of like a slinky there, which shows she actually moved during the acquisition of the tomosynthesis. So if she's moving, these small calcifications are going to have motion artifact, and they are not going to show up on either the tomosynthesis slices or the reconstructed synthetic image. And if you're not sure about that, you can go to her so-called projection images, which are the individual low-dose images, and you can run those in a loop, and you can actually see her pectoralis muscle bopping forward and backwards as she's breathing during her acquisition. So in this case, you know that you're not going to find faint calcifications on that view because there's motion. So you recall her, and indeed, this was DCIS, seen only on that CC view because she was moving on the other acquisition. So one of the first outcome studies of synthetic imaging was done by Fiona Gilbert in the Tommy trial in the UK. And she found, compared 2D mammography, 2D plus tomosynthesis, and then synthetic plus tomosynthesis, and found the sensitivity was pretty much the same. It was okay overall. And then you can see here the specificity actually improved as you went to combination tomo and then to synthetic tomo. So less false positives, interesting. But what was really important about this paper is the statement that was kind of buried in the discussion. She said, overall, synthetic and tomosynthesis had better sensitivity for invasive cancers than 2D. However, synthetic was inferior to both 2D and combination tomosynthesis in finding calcifications of DCIS in cancers DCIS 11 to 20 millimeters. So there was a little problem finding some subtle DCIS. So we looked at our early outcomes, and we had, when we implemented tomosynthesis in the fall of 2014, we allowed a 4-month overlap where we had synthetic, 2D, and tomo, so that we could go back and forth and look at the appearance across all 3 techniques. And then we decided in January, about 4 months after, January 2015, to drop the 2D digital component in our screening cases and do a natural outcomes analysis, looking at recall rate, cancer detection rate, and PPV. And that was published. And what we found was that our recall rate went down. From 2D to combination and now to synthetic, it continued to go down in a statistically significant fashion. We also saw that calcium, asymmetries, and even our technical callbacks went down statistically significantly. Our masses stayed about the same, and our architectural distortions actually increased slightly with combination tomo and synthetic compared to 2D. Our dose was decreased by 39%. Now, remember, I estimated it would be based on phantom measurements, that it would be reduced by 45. Actually, we didn't see that reduction. We only got to 39%, and that's because we actually have a lot of big breasts in Philadelphia, and we are tiling and doing additional imaging frequently on some of our women. So that's why we didn't see the 45% reduction, but rather achieved a 39% reduction. But we maintained our low recall rates, and we actually decreased in some lesion types the recall rate. But let's look at our cancer. So our biopsy rate went down statistically significantly. Our DCIS went down. Our invasive cancer actually went up slightly, but not statistically significant. But look at this. Our DCIS trended downwards. It wasn't statistically significant, but still. And our PPV1 and PPV3 increased, PPV3 statistically significantly. So we maintained the benefits of tomo, and we continued to increase our cancer detected, reflected in our PPV1. Sensitivity, specificity was similar, but there was a slight decrease in the detection of in situ cancers that we wanted to continue monitoring. Is it that very low density calcifications of DCIS, amorphous DCIS, may not be visible on synthetic reconstruction? Interesting. Well, here's some more data from another study in 2017, also showing a slight decrease in DCIS here with synthetic compared to combination tomo and 2D. Interesting. Is this okay? Is this just overdiagnosis? These very subtle low density calcifications of DCIS will catch them next year? Or are these cancers that could be bad cancers and cause interval cancers and have rapid growth rates? We don't know this yet, but it's something that needs to be monitored. Here's a prospective trial, the Verona screening trial. Look at how much this is actually looking at synthetic tomo versus 2D. Their cancer detection rate went way up. Remember, they have a longer screening interval, but interesting also, their in situ numbers went down slightly. So this is still an active area of interest. You know, we need more data and follow-up, long-term follow-up on these women. Here's a very recent, actually still an e-publication, a reader study looking in synthetic versus 2D and tomo for calcifications. They found no change in the sensitivity or the negative predictive value, and this is 2D versus synthetic reconstructed 2D. But they did find a decrease in the specificity and the PPV with synthetic. So again, further, I think, evaluation and long-term outcomes are going to be important. Their readers thought that calcifications, when they saw them, were more conspicuous. Remember, they're somewhat enhanced, that synthetic pop of calcifications. So what about diagnostic imaging? Well, we know that women benefit with tomosynthesis because the quasi-3D reconstruction, we can triangulate. We know that we decrease the additional imaging with tomo. We also improve the sensitivity and specificity, so we do less spot views. We see the margins better. We certainly still need to magnify calcifications, but we are bringing down the extra imaging. Here's an example. A 66-year-old woman with a lump in her left breast. There's a BB, I hope you can see it there, sort of at her periareolar lateral left breast, right there. And look here, her 2D images are in the left column, her tomosynthesis here. Very hard to discern anything. She feels this, but we cannot see it well on her 2D. But look at the spiculated mass that comes out on the single 1 millimeter reconstructed tomo slice. So when we see that, we don't have to do extra views. We go directly to ultrasound, and there it is. This is an ERPR HER2 negative cancer corresponding to our palpable lesion. So we don't need extra views here. We go directly to ultrasound, and we published this from a multi-center trial looking at what kind of imaging women get at recall. So this is the type of imaging on the left they get at recall, and this is in the tomosynthesis. This was 17,000 recalled women from about 26,000 screens. So it was a very big multi-center trial versus 2D, what was done at recall. And while most women at recall get mammography and ultrasound, interesting, many fewer got mammography only compared to the 2D workup. So 31% got extra mammo views with 2D mammography, only 3% got only mammo with tomo. So many less straight laterals, less extra views. Ultrasound only was the other big one. Many more women went directly to ultrasound with tomosynthesis evaluation than 2D. This is from screening. There were tomosynthesis at screening, then recalled versus 2D, recalled. So many more women going directly to ultrasound, a more efficient workup for the patients, less extra imaging. And actually, we looked at time to biopsy, and there was a faster median time to biopsy with tomo than 2D. And category 3, I hate category 3, short-term follow-up, 6-month follow-up, I think you're going to be okay, less than 2% likelihood of malignancy. But we found with tomosynthesis that we actually decreased the number of BI-RADS 3 cases. And when we looked at it as percent of recall, it was actually about the same, but the overall number of women was decreased. 3 per 1,000 women screened, less were put into category 3. So that's a really good thing. We really dislike category 3s. So I want to finish up just with one of my favorite topics, tricks of localizing lesions. It's not as easy as you think. And it's tomosynthesis, you think you've got 3D information, but it's not always as straightforward. Here's one that we did not do too well on. This is a woman with very complicated nodular breast, 51-year-old. She actually had a history of a scar here. Can you see my red markings? And there. So in the lateral right breast and the upper outer sort of axillary tail. And on her tomosynthesis image, this was seen. Do you see the area of distortion there? Whoops, here we go. Out here, an area of distortion. And this was only seen on the CC view. Remember, only on the CC view. Pay attention to those. And here, she was told it was normal. It was just her scar tissue. She came back 1 year later, and there it is again, and it looks even worse. And now it sort of has a mass in the center of it. And this time, the triangulation was done correctly, and I'll show you why. This is a blow up of the yardstick or the localizer. It's not in the upper outer breast. It's towards her foot. It's in the inferior breast. So that doesn't correspond to her skin scar at all. And if we look carefully in the lower half of her breast, that is the spiculated mass lateral on the localizer. This is an MLO view. Now we see it in 2 projections. We can target our ultrasound. Remember, that was where her scar was. Up in the axillary tail, not down there, makes no sense. It is not her scar. Targeted ultrasound, and this was an invasive ductal carcinoma. So you've got to use all your information and make sure the triangulation is correct. And again, any hesitation, ultrasound. Here's another case, and this was a negative 2D mammography, a 68-year-old woman with fairly dense breasts, but on her tomosynthesis image, in the lateral breast, I think you can see this area of subtle distortion that triangulates to the superior aspect of her breast. Here we go again. I think I've got mag views just to show you. It localizes to the superior breast, so you look very carefully and you can subtly see an area of distortion in the superior breast. Again, not well seen on that MLO view because the compression is really weighing heavily and the force is applied mostly to her pec, not to her breast tissue, but much better seen on that CC view. Targeted ultrasound shows obviously category 5 suspicious lesion. There it is on an MRI, exactly in the spot where you think it is on the MLO, and this was an invasive lobular carcinoma. So use your information carefully. Now this was a tricky one. Believe it or not, this was an 87-year-old woman who was getting screening mammography. I'm not quite sure at that age why, but calcifications were seen on her 2D image here. I hope you can see those little teeny, well, actually radio opacities, thought to be calcifications, and she was sent to our site for a stereotactic core biopsy. But on looking at her tomosynthesis, these are incredibly superficial in her breast. Do you see that? At the very early slices. And I'll show you these 2 images. And look where they localize. Here towards the head, and I think, I don't have the localizer for the other one, but also in the medial breast on the MLO. And these were actually within the skin. And this was an ointment that she was putting on a rash. They were not calcifications in her breast at all. But my question to you is, why don't they therefore localize to the first layer of the skin? Well, this is called the bending paddle effect. And I drew these pictures, so excuse my art. But in the particular industry that we use, the paddle actually will bend, and the reconstruction algorithm will extend beyond the skin into the bending paddle, so that you may see skin lesions looking like they're 5 millimeters or even more below the skin surface, and you just need to appreciate that. So here again, skin calcifications, you're trying to figure out if they're skin. Well, you put the side of the breast where you think the skin calcifications are against the detector, which is hard, and the reconstruction begins right at the detector. And again, this is in the MLO. We have here at the lateral breast, completely in the skin, the first slice, do you see that? But on the slice where the paddle is and the bending paddle effect takes place, they don't look like they're in the skin at all, but we know for sure there are. And that's because of these extra reconstructed slices to account for the bending paddle effect. So remember, if you worry that you've got some skin calcifications, you want to prove it, put that side of the breast against the detector and repeat the image, and you'll see that, to overcome the bending paddle effect. Here's another example of a case that was sent to us for a stereo of a developing asymmetry here in her medial breast. Where is it? Possibly there. They couldn't find it. They said stereo it. She came to us and we're like, maybe it's skin. We put a BB over what we thought was a skin lesion, repeated this view, and here's the tomo slice. Does not appear to be in the first slice of the reconstructed slab, but there it is. Ultrasound was performed, has the typical neck out to the skin where a punctum would be, and this is a typical pathognomonic appearance for a sebaceous cyst. But you should know about the bending paddle effect because they will not always triangulate to the skin. Again, in this case, her bending of the paddle was about 8 to 10 millimeters, so a lot of paddle bend. So understanding that. Also the importance of the rolling nipple. The nipple is the center of the universe of the breast, and we like to think of our nipple to pectoral line as perpendicular to the pec. Well, on compression and with elevation of the tray for a really nice deep mammogram, the nipple will often roll. So it's actually eccentric and lower towards the detector side. And therefore, there'll be more tissue above the reconstructed plane of the nipple than below. So let's look at an example of that. Here's a mass. The mass is in focus here in her breast on the yardstick. Here is a subtle area of distortion above the level of the mass, and I magnified it here. Very, very subtle, about 4 centimeters of distortion above the mass, which looks like it's in the center of the breast on the localizer stick. Now let's look here. The tricks are first find the nipple and then triangulate from the nipple. So I've got the nipple on FOSS here, nipple in focus. I can see the mass in focus with sharp margins. So I know that the mass is at the nipple axis and the right breast laterally at 9 o'clock. Now my distortion is above the nipple and above the mass. And now I can look on my other view and go, well, where is it? Boy, it's hard to detect. Here's the mass. Where's the distortion? Where's the distortion? Oh, wow, look at that. It's a flat plane here, but it's got to be up here, not at the nipple axis, but above the nipple axis. And indeed, that is the abnormality. There is the ultrasound, had multiple areas of shadowing. This was an invasive lobular carcinoma. The mass was actually a simple cyst. So learning to look and triangulate from the nipple because it frequently rolls in tomosynthesis is important. So to avoid mislocalization, remember about the added slices and the bending paddle. Find out with your industry about their reconstruction algorithm and how they deal with the bending paddle. And remember about the true center of the breast, at least for triangulation and o'clock measurements, is working from the nipple, but the nipple axis in a tomo is not always in the middle of the breast. So find the nipple and triangulate from there. So let's wind this up. Tomosynthesis, I believe, is the new better mammogram, improvements in sensitivity and specificity. We need more data on false negatives and long-term outcomes. I do believe that synthetic is okay and maintains the benefits at a reduced dose. We'd like to have further data and improved algorithms over time. And then finally, remember the tricks for localization so that you can find those subtle lesions, particularly when they're seen on one view only and often the CC view. So thank you all very much. Obrigada, obrigada again. And this is one of my favorite women. She's in New York and she is very dense and has a lot of breast tissue. And with that, I'd like to end and thank you all very much and take any questions.
Thank you, Emily. I could be here until tomorrow.
Thank you very much.
Do you guys have the screen now?
Thank you very much. Was a very nice. Sorry?
Do you have the screen now?
Yes.
Okay.
Yeah.
Thank you, Dr. Conant.
You're welcome.
And we will start a Q&A shortly. So just let me hand to Fabiola for her to make some comments or questions. Or Fabiola, so please, if you'd like to address our audience.
Well, Emily, as you know, we have a completely different reality from Pennsylvania. We have here less than 10% of our mammographers are digital.
Yes.
So you can imagine tomosynthesis is not a reality here. I'm very lucky because I work only with tomosynthesis. But you know, I have a problem. I don't know how to deliver synthetic view to the gynecologists. They are not used to it and they complain about it. So because I work in a very private scenario, how do I show them? How can I show them that it's safe to have synthetic imaging? Because for me, it's very safe.
Yeah, I think you need to show them examples and the importance of the dose over multiple screens of a woman's life. It really adds up. And if you look at the very thick, fatty breasts, I'm not sure how much of those you have, you know, where you are, but in my city, we have some very thick breasts, and the exponential increase in dose when you're doing both a 2D and a tomo, it really adds up. And I think showing them some dose tables and then examples like I showed of cancers really seen better with synthetic.
Yes, you know? I believe so. I do. I really believe so. I just have to make them believe too. But you know, here in the tomo scenario, in the population that can have tomosynthesis, we have a lot of women with implants, with silicone.
Yes.
So this is another problem because we have to do the full exam, you know, the 2D, the 3D, and the echelon. So it's a lot of
those.
It's a lot of those. So we have to get them used to the synthetic view. We are doing this now. I think we are teaching them.
Yeah, and Fabiola, I also think if you can screen capture the slice that the abnormality is seen on tomo, and also show them the synthetic, you know, that it's the combination. The synthetic's really used for sort of global assessment, calcifications, density, that they'll begin looking at the tomo and not depending so much on the 2D.
Yes, we are getting there. Actually, now we have to be free from CR mammographers, which for me is the worst villain in those, because they are completely irregular and heterogeneous. So we have to be free from them.
Yeah.
And then we go in the tomo way. Yeah. Don't you think so?
But you, I gather most of your tomo is for diagnostic imaging, not screening.
We don't have this, you know, this separate, because in United States it is very sharp. This is screening, this is diagnostic. Here it's very mixed. So we don't have these numbers, but mainly we use tomo for screening.
Got it. Good. That's, I think, the most important place.
Yes, that's where we have to use it.
Yes.
Isn't it? And ultrasound is very strong in Brazil. So we have this as a tool. We can use ultrasound a lot to improve our detection, I think it's better than the United States.
Yes.
Only this part.
Yes, I think so too. We don't do, well, some places do a lot of supplemental screening with ultrasound. And I think, at our site, we do abbreviated MR.
Yes, I know. This is not a reality in Brazil. We can't do MRI. We have to improve our mammographers around Brazil, and MRI is not a reality here, not at all.
Yes, and we've made it so the cost is the same for a woman in my city to get ultrasound as it is to get abbreviated MR.
Yes, maybe one day. Yeah. Now we have very, very inexpensive ultrasound.
Yeah,
not
expensive.
I cannot say that they are good, but I can say that they are not expensive at all.
Good.
I think that this is a very critical issue that you're talking about, Fabiola, for Brazil, because as you know, Dr. Conant, it's a low-income country, and we struggle a lot to finance our private and public health systems. And most of the women, as Fabiola was explaining, would get a 2D mammogram and an ultrasound. And most of the comparisons that we see on literature, and you showed us, a lot of them are comparing tomosynthesis to 2D mammogram.
Yes.
And for us, would be very important to understand what would be the improvement in performance when we compare 2D mammogram plus ultrasound versus tomosynthesis, and eventually with ultrasound too. Can you tell us a little bit if you had some data that would compare this scenario that would be more like our reality here?
Yes. So, there's studies that will show anywhere from 1 to 4 per thousand additional cancers with supplemental ultrasound, depending on handheld, whole breast, automated, and which round of screening with supplemental ultrasound. So it really is very much, I think, operator dependent and the technique.
Yes.
And I know you all do very good ultrasound. So let's say that you are in the, we'll make you the best, 4 per thousand additional cancers with your supplemental ultrasound from 2D. So you're going from maybe 5 per thousand to 9 per thousand. By adding ultrasound. Yes. By adding tomosynthesis, you're maybe getting, 2 more. So you're getting still 2 additional with ultrasound. So you're still adding to that, which is good. And the ones you're finding are the invasive cancers, which are the most significant ones. It's not more DCIS, and we could have a long discussion about overdiagnosis. But you're really finding the masses. And that's good. The question is, what are the false positives? And in the United States, that's the negative. And there have been some really interesting recent literature from the BCSC, which is a big national database, looking at what's really happening out there in clinics, not under an academic trial with added ultrasound. And it's really not finding 4 extra cancers per thousand. It's finding maybe 1, and there are many false positives, many short-term follow-ups. So the cost effectiveness is not there in the general hands of the general radiologist that's doing it across our country. And, that's where it gets sticky, because we've got this whole breast density movement in the United States about telling every woman, and, she's dense and scaring her, and, and then we're not offering much. And so that, for another day perhaps, is where a super fast, MR, we've been doing it for 4 years at our site, and our cancer detection rate after a negative tomo in an average risk woman with dense breast is 27 per thousand screened. So we're going from a 6 cancer detection to 27. That's pretty crazy. And they're little node negative invasive cancers mostly, or high grade DCIS, not the overdiagnosis type of lesions.
This is one very critical issue also, if we may get into this controversy. I know this is a sensitive issue. because we know that one of the major criticisms to mammography screening is overdiagnosis.
Yes.
When we see the introduction of a test that's more sensitive, we see, don't you miss a lack of evidence of clinical benefit, because most of the studies will just look at the detection rate. And so my question is, do you miss this clinical benefit in these studies, or do you don't believe that this overdiagnosis thing is a big issue?
Oh, I'm a moderate, but I believe in overdiagnosis, and I think that's one of the reasons I brought that up with the synthetic imaging. Are those significant calcifications that we might not see? There are going to be non-calcified cancers we can't see that can be very bad. And that's what I think abbreviated MR will find. I truly believe that we do overdiagnose things, but I truly believe tomosynthesis may find things just a little bit earlier and give her a smaller incision, but that we might have caught it next year or the year after because it's an ER/PR, garden variety cancer. And that brings up this whole question of precision screening and how we really need to do that better. We need to risk assess better. Fabiola knows one of my favorite research areas is looking at the, quote, complexity of the breast. If you open up a mammogram, I'm sure you've seen them, and you look at it and she's nodular everywhere and she's got calcium everywhere, and you think, oh, she's probably 50. And then you ask her age and she's 67, you go, oh my gosh, that's a risky breast. And so how do we incorporate that, really the phenotypes of the imaging findings that reflect a lot of risk into our decision making? And I think that's where we need to go over time, as well as, better risk assessment based on age, race, all sorts of things. We're doing liquid biopsy stuff now. There's a lot of great stuff on the horizon because we still have issues with overdiagnosis, underdiagnosis, false negatives.
Dr.
We
Conant,
have a question, very interesting question here, is about, do you believe that these cancers that we are finding in the tomo, we are going to have a decrease in the mortality finding them? Do you believe it?
So I think in some groups, and that's why I showed you the data from our site in that most recent paper, we have a lot of young Black women who have triple negative cancers, and we're finding more of those with tomosynthesis than 2D because they're dense and complicated breasts. And so I think that if we look at subpopulations at different risk, we will find impacts on mortality. In the whole big general population, I'm not sure we will. I think we'll decrease morbidity because we'll make some surgeries, maybe downgrade the chemo, maybe no chemo, things like that, which are very good. But mortality is the gold standard.
Dr. Conant, as a breast surgeon, it's almost impossible to believe in Brazil in overdiagnosis. Every day we fight with palpable lesions that we missed them in a poor mammography, in a CR mammography, that we know that these lesions once ago was a impalpable lesion. So when you show us the data about the women between 40 and 49, the breast density, the specificity, the PPV on invasive ductal carcinoma, and for us is not important in Brazil nowadays, the CIS. This is true, not reality. We are worried about people with palpable lesions, node positive, that we missed in ultrasound, we missed them in mammography, that it's not ideal. So as a breast surgeon, for us, when we see the possibility that tomosynthesis has to decrease the recall, to increase the invasive detection, it's really that we need. And for mortality, it's not the only thing that we are looking for when we're doing screening. We are trying to detect the small lesions that we can use less chemotherapy, we can do more conservative surgeries. And this is the role of tomosynthesis that can help us to treat these women. I think that is the very things that we have to do, not be focused only in mortality.
Yes. Oh, yes. I agree. I'm a big believer in tomosynthesis, because to combine improved sensitivity and specificity together, that is really a double win. And that is so important, and it should be the standard, I think, mammographic imaging. I have no doubt in my mind. But of course, we need other data as well, I think. So I totally understand what you're saying. And, that's why we have done tomosynthesis since 2011 on everyone.
Okay.
The problem is when you begin to work with tomo, it's forbidden to go back to mammography.
It's true.
You can't read mammography anymore.
It's true. It's
because
true.
you know that you're finding things that doesn't exist.
Yeah.
And you are sure that you are not finding the right things you should find.
Right.
So it's impossible to continue reading mammography when you begin to read tomo. I have a question here that if you work with digital mammography and ultrasound for everybody, do you think tomo is going to be better?
Yes.
Yeah, I believe so, because in ultrasound we have a lot of BI-RADS3. Those BI-RADS3 that,
yes, they drive you crazy.
Nothing.
They drive women crazy.
Yeah. And this we don't have in tomo.
We have here a question from Monica Travassos.
There are some questions from our...
A suspicions in palpable lesions seen only on tomosynthesis. What is the probability of not being seen in a pre-surgical appointment, in a stereotaxia on digital mammography?
So it's a suspicious non-palpable lesion seen only on tomosynthesis. This does happen. And we therefore have tomosynthesis guided biopsy, and we do find cancers, unfortunately. So, this is a problem. If a woman has a tomosynthesis and then goes off to somewhere that doesn't have tomosynthesis and it's not visible on ultrasound, what I would recommend is someone, if they can't biopsy on, with a stereo tomo, at least put a clip in under tomo and send her off to the surgeon, who will then excise it. Right, Fabiola?
Yes, it's the same. Yes, it's the same that you have when you find a lesion in MRI, for example, and it's seen only by MRI. You have to do the biopsy guided by MRI. So, for example, it's not a lot of lesions that you see only in MRI. It's not a lot of lesions that you see only in tomo. But if you have tomo, you need a tomo system to biopsy near you.
Yes.
You don't need a lot of tomo system all over the city, but you need at least one.
Yes.
Yeah, exactly what happens with MRI.
Exactly.
If you have MRI, you need someone to biopsy by MRI those lesions that you don't find in ultrasound. So it's possible, but it's rare, and you can manage.
You send them to Fabiola.
I think there's a lot of people that do that, and it's difficult.
Fabiola, we have
Yes.
another question from audience. Evie Paula at 90 and 5. How about architectural distortion in digital tomosynthesis without ultrasound imaging or MRI enhancement? Do you biopsy this lesion?
Yeah, it's going to be a tubular or
Small invasive
radial
lobular.
scar.
Yeah, radial
Yes.
scar. Do you know that in the beginning of MRI, the false negatives on MR are invasive lobulars, because they can be slowly enhancing, just morphologically a little distorting, but not like an invasive ductal, rapidly enhancing. So it can be tricky. But so yes, it needs to be biopsied.
Yes.
Do you see the same difficulty we have with lobular cancers in 2D mammogram with tomosynthesis? It's also a tricky lesion?
Yeah, still a tricky lesion. I think the one I showed you, the woman who wasn't very dense, that was subtle. You know, again, I think it was seen initially on the CC view as just a denser area that on the tomo slices showed a little distortion, and then looking carefully on the MLO view, you could discern it, but it was not your typical cancer. So still hard, but maybe not as hard.
Yes, it's hard, but it's better.
What about this extremely fatty breasts? Can we dispense with tomosynthesis, or do you still need tomosynthesis with very fatty breasts?
Yeah, so the incremental cancer detection rate with tomosynthesis is not as great in the extremely fatty breast. So you're right, it doesn't have as much, can I say, big bang for the buck, meaning you don't get as much an impact. It is interesting, though, that you will decrease your recalls still, because you'll see this superimposition of little areas of scattered glandular tissue and things.
Yeah, I think what's important in fatty breast is that if you have a little bit of parenchyma, the tomosynthesis will help in that part. Because sometimes you have a very fatty breast, but in, for example, retroareolar region, you have a little bit of parenchyma. And it's in this area that you need the tomosynthesis. Yeah. So actually tomosynthesis help almost.
But I think it's the false positives more than the cancer detection, but I agree.
Yes.
And,
yes.
You know, again, it's hard to go back to 2D once you've been reading tomosynthesis.
Yeah. And you said that the algorithms have been improved a lot, and the synthetic view, we don't have an issue anymore with microcalcifications. Is that correct?
So it depends on the industry that you use. Each industry has, you know, their different secret recipe. I know that the one that we use is now on its 3rd rendition and now does a higher spatial resolution acquisition without binning at the detector. That's a lot of physics. So it's pushing it closer to a 90 micron when it used to be like 120, 140. It makes a very large file for storage. That's the downside. But the pictures, the synthetic is looking more and more like a 2D mammogram. There's less artifact, a higher resolution. But we haven't done the outcomes on that yet.
I have a very radiologist question. How do you storage all those images? Do you have this for 5 years, 10 years? How many years do you storage? Because it's a lot.
Yeah, we have to store. We're not allowed to throw away mammograms. So we store them, and we have off-site storage that we may, you know, takes a little bit to retrieve if we want 10 years ago, but we still have the ability. We only store the reconstructed slices. We do not store raw images.
Okay, this is nice. Okay.
Yeah. So we do the synthetic and the reconstructed slices, but not the raw, and honestly, not even the projection.
Okay, thank you. This is very helpful.
Yeah.
Fabiola.
When you're doing a biopsy, go ahead, Eduardo.
Do you believe that in Brazil that our main problem to have tomosynthesis costs? Or you
yes,
believe
for sure.
Only this?
It's cost. Yeah, only cost. Only cost. Everybody would learn. Everybody would love to work with tomosynthesis, but it's prohibitive. Yeah, it's impossible to have tomosynthesis. You know how much we pay for a mammogram.
Yeah,
it's a very expensive equipment, and now the dollar is high, so the equipment is more expensive, and it's really difficult. I think we have more. I think we have more serious problems to think about before go into tomo.
And the learning curve for the radiologists to learn tomosynthesis, is it difficult?
I think it's very quick, don't you think, Emily?
I do. You know, it makes me worry that, you know, anybody can do it, huh, Fabiola?
Yes, even the computer.
Right. Are we going to get out of job because of AI?
You know, there is I've written a paper recently about AI for tomo, and the performance is really very good, and it decreases the reading time, and relative to the average reader, it's, you know, doing very good. I still think that you need a radiologist overseeing and helping, but I think it can be very helpful in terms of sorting lists and prioritizing, and also calling your attention and maybe making you more efficient. But again, that costs too.
Yeah, and I think radiologists, we like to see positive mammograms. We like to see problems. We don't like to see screenings and screenings and screenings, and to see, for example, 50 screenings to see one lesion. So if we have artificial intelligence, they are going to remove all those normals, and the good ones are going to be for us.
Right.
So I like the idea of not screening anymore.
Yes, so there you go.
And looking only to the good cases, you know.
Fabiola is such an avant-garde radiologist, because seriously, you asked about the woman with the entirely fatty breast. In my future, I see the non-complicated breast, the no CAD marks, you know, fatty breasts that Fabiola and I don't need to read, and certainly in Europe, they don't need to double read it.
Yes, so, double read. Can you imagine double read?
Right. So, you know, if we can skim all those off and keep those crazy complicated ones that make us pull our hair out, and then Fabiola and I can double read those together, we would be so great, right?
We're going to be very happy.
Yeah, with the AI as well. And we can do it remotely and virtually from Brazil to Philadelphia.
Welcome, AI.
Fabiola and Dr. Emily, we have a question from Dr. Josebines. Here is a friend of mine. Would you be concerned with the amount of radiation for BRCA1/2 mutated patient screening?
So, you know, again, we know that, you know, we don't want to over radiate them, but we really do want to see their cancers. And so particularly, as you know, the BRCA2, BRCA2 tend to form calcium cancers. And I remember that in a silly way. Ca2, it's the, you know, elemental sign for calcium. BRCA2s, actually a lot of their cancers present with calcium, and some of them are only seen on mammography or not on MRI. BRCA1s are the triple negatives more often. And so when there was a famous, believed by Plevritis, cost effectiveness, it's really the BRCA2s that it's most cost effective with mammography and MR. BRCA1s don't benefit as much with the mammography, but again, the tomosynthesis brings a whole nother dimension because it will find masses and things that are otherwise obscured. That was in the 2D time. So yes, they need their screening at our site, and ideally we stagger them every 6 months. Mammography and then MR, mammography and then MR. And we see some amazing things grow in just 6 months' time. Okay. So I do think they need it, and I would not be concerned about the radiation. I think they've got bigger concerns of not having their cancer detected.
Yeah. As a follow-up to that, does the dose for a biopsy guided by tomosynthesis is an issue?
Oh, this is a favorite question. We have a paper out right now. You would think that tomosynthesis guided biopsies are larger dose, you know, biopsies, but actually because you only need the one acquisition, that one acquisition is about 1.2, 1.4. In a stereo, you need this one, you need the scout, here and here. That's 3 dose, right? So a tomo biopsy guidance is actually less dose overall.
Yes, it is.
It doesn't seem, you know, it wasn't what I thought initially, but when you do that math, because you don't do the scout and then the stereo imaging each time, you actually do less imaging over time, and overall the dose is less with tomo guidance. It's a good question.
Okay. Is there other question from Francisco Pimentel? Is there a role for tomosynthesis after neoadjuvant chemotherapy?
So, you know, I really think MR is the way to go for that myself, because you're really looking at the degree of enhancement, and you really want to stage and look at the extent of disease and how it's shrinking. And we know that with neoadjuvant, if the response is a shrinking sort of imploding like this, there's a better chance of resection and no residual, versus the cancer that instead just kind of melts and leaves multiple dots of enhancement around. He's still going to need a mastectomy. So it's the pattern of enhancement as well as the overall decrease in enhancement over time and the volume of enhancement. So if you're going to monitor these patients, I would go with MR if you can. We also know that calcium doesn't always disappear with neoadjuvant. And if that's what you're watching on a mammogram, it could still be there, you know, after neoadjuvant.
Okay.
Yeah, well, I think I agree. I think the exam for chemotherapy, neoadjuvant chemotherapy, is the MRI. They always try to use other, like ultrasound or mammography if you don't have tomo, but it's not the right exam.
Fabiola, we have a comment from Rodrigo Pepe, an interest comment. As tomosynthesis reduce the false positives, maybe globally it can reduce the cost if you put the same biopsy cost, screening cost, and positive value of the, maybe generally we can reduce the cost. It's a interesting point of view.
Yes, I think in Brazil, I think we have one thing that would reduce costs a lot. It would be a very serious training. This is the best thing to do, to train the one who's doing the reports, to go to the north of the country, to poor areas, training people there to report. That's what we are missing. It's not putting a more efficient machine or more modern machine. It's to train people who are there. I have an example. My husband goes to Africa to train surgeons how to do surgery. They don't go there to do the surgery. They go there to teach people to learn to do surgery. That's what we have to do here in Brazil. We have to teach them to report. And this is going to reduce costs a lot. They are not going to do a lot of ultrasound or the ridiculous MRIs that we are doing to solve problems that were not there. Mm-hmm. Well, so I don't think actually tomosynthesis is the solution. I think, and it's not going to reduce costs that high that you could use to buy an equipment.
So let me just make one comment on that. We did do we published in, I believe it was JNCI last year, a cost effectiveness study based on our multi-center trial. And right now in my area, if we charged women, which we didn't for many years, charge women, it was an additional $60 that insurance was going to, pay, or some places out of pocket. When we did the cost effectiveness and took into consideration the decrease in recall, the decrease in false positives, the increase in cancer detection, and did modeling, it was cost effective, but not at the $60. Maybe at like 40. So it does bring value and can, be equalized to be cost effective if it's at the right price. So I think Dr. Pepe is thinking correctly, but you've got to make sure that, it's a reasonable amount that you're charging and you're not overcharging. And also that the industry is not overcharging for the, the machine. Yeah. The upfront cost.
Only curious, Fabiola, and in Brazil we are some groups are talking about enhancement contrast mammography. Do you believe that we will have enhanced tomosynthesis, contrast tomosynthesis too, that could be help to detect?
It's a very, very, very interesting area. It's a very interesting area. I have no experience at all, but Dr. Emily has a lot of experience in that.
So we did that way back in 2005 or 6, and we compared contrast tomosynthesis to MR, and it's actually pretty good. Most places are doing contrast mammography, 2D mammography. I would argue, and some of the new equipment allows you to do contrast tomo, that's the way to go, because you get the 3D or quasi 3D reconstruction for localization. You can now do a biopsy guidance, and you can put the contrast in. So I think that actually is a very, very good thing to do. We only did a series of about 15 patients that had a known cancer, and we were looking at extent of disease. But I actually think that that's a good, less expensive answer to having contrast and this quasi 3D information. So I would, look to do that.
Okay.
Are you afraid to do the mammogram contrast in a normal facility out of the hospital? Do you
It's a little more
trust?
tricky. It's because you need to have people who are capable of, responding to contrast reactions. So you wouldn't want to just be doing that anywhere where there are not people that are around.
Yes,
but it might be
afraid
good
of
for high-risk
that.
screening or intermediate screening that can't get an MR. You don't have an MR in the area. Again, I think it's got great potential, and it's an interesting area to pursue. So whoever asked that, good question.
We have a question asking, because we have a lot of breast reduction surgery here in Brazil. So we have a question asking if tomo helps you in this kind of breast.
It does, but if a woman has a lot of capsular contraction and you can't get displacement, it's a tough mammogram no matter what, even with tomosynthesis, because you're not, particularly if it's silicone.
Yes.
It's just very hard to displace the tissue if there's a lot of capsular, contraction there. So I think it depends on the breast, but certainly if she's got a pliable breast, it's better to do tomo.
Oh. Any more questions, João?
Yeah, there is one question from Eric here. He wants to, at 9:16, he wants to go back to Dr. Bini's question. He wants to add the question about the BRCA patient. If your rationale would change in relation to the age of the patient. If a younger patient would have to have a series of screenings and more dose of radiation, if that would change your mind in terms of adding tomosynthesis to her screening routine.
So if they're really BRCA 1 or 2, we start imaging at 30. And again, we're doing MR and mammography. Many of these women are not going to be keeping their breasts beyond childbearing years. So that isn't our concern, the long-term radiation issues. It's getting them through the years where they are out in the world, meeting people, then going to have babies, and then are going to probably get prophylactic mastectomies and oophorectomies. And so our goal is to get them through that period. It gets more complicated when you talk about, genetic variations of unknown significance in, high family penetrance groups. And we begin screening 10 years before the first degree relative was diagnosed, but not earlier than 30. There are a few variations to that, like check mutations and some others, but again, we usually start at 30, but 10 years below the first degree relative, but no earlier than 30.
And changing gears completely now, in this pandemic, are you seeing a decrease on women looking for screening, and you are expecting to see more large tumors the next?
Oh, COVID. you know, I'm sorry, it's getting dark here, and I don't have an office at home, so I only have a light on. So if you can't see me, so this is a very interesting question, and we're looking at this nationally because we do believe that the delay in screening is going to lead to larger tumors at diagnosis. And then we've done surveys asking women whether they want to come in for screening or not. It's very dichotomous. Some of them are like, oh my gosh, I'm 2 months late, I've got to get in, you know, and they come in and they've got triple masks on and gloves, and they tell the technologist, don't talk to me, don't touch me. And we're like, how do we do the mammogram? And then we've got a whole nother group of women who are like, I'm just going to skip this year. Thank you very much. And so I think we have to look at the two groups, you know, who they are, what their risk levels are. But I do worry about it. We are seeing more delay in even symptomatic women with lumps coming in. And we have been recently seeing a lot of bad things that just women did not want to come to the hospital. And I have to say, the infection rate at our hospital is less than in my city because of all of our temperature taking gloves, face shields. I think we're pretty safe in the hospital.
Fabiola and Dr. Emily, you are until now receiving many words of congrats for the presentation and discussion. Everybody in our comments are really happy with this presentation. I think that we had finished our objectives with this night to discussing not only tomosynthesis, but diagnosis, overdiagnosis, how to biopsy, and how we can help patients with breast lesions to get their diagnosis. So I'm very happy, and I think that it's a special night for us to have you tonight with us.
Yeah, well, thank you. Whenever Fabiola calls me, I say yes.
Well, thank you so much. We appreciate you taking the time and sharing that so much knowledge with us. Thank you, Fabiola. You were very kind as usual. Your mic is on mute if you want to say the final words.
Yes, I want to say thank you. Thank you for inviting me. Thank you
Virtual hug.
The opportunity to invite Emily, because Emily is really special. Not only because she's a great researcher, but she feels what's important. I don't know.
We could feel that very much tonight.
Okay. Okay.
Yes, I know.
Thank you for having me. Very nice to see you all again. Okay. And be safe, be well.
Be safe.
Bye.
Yes, we will. You too.
Okay. Bye-bye.
Bye.
Então, pessoal, lembra de dar um like e se inscrever no canal aí. E boa noite a todos. Obrigado.
Boa noite. Fabiola, brigadíssimo de novo.